Hello, everybody. This is a webinar prepared by Interasthma. I thank Interasthma for this invitation to be moderator of this session. The topic of this webinar is key messages to improve outcomes for people with asthma and COPD in low and middle income countries. My name is Nelson Rosario. I'm a professor of pediatrics at the University of Paraná, and I have the honor to introduce Professor Alvaro Cruz, who is a full professor of internal medicine at the University of Bahia. He is going to be our speaker today, and I am sure he has key messages regarding people with asthma, especially in low-income countries such as Brazil. Professor Alvaro, go ahead. Thank you very much.
Thank you very much, my dear friend Rosario. I'm very pleased to take part in this series of webinars by Interasthma. And I'm very grateful for my good friends from Interasthma, including Fulvio, and Louis Philippe, and Walter, and yourself. I think the topic was tailored to me, was personalized to me, and it's a pleasure to talk about this very, very important matter. Let me share my screen with you so that we start talking. Well, I hope you all can see this front page. Well, besides being professor of medicine of the School of Medicine of the Federal University of Bahia, Brazil, I'm also the executive director of Prof Foundation. Well, let's begin with this foreword of a publication called Preventing Chronic Disease, a Vital Investment by Dr. Lee, a former director of WHO. This was published in 2005, and he calls attention to the cost of doing nothing, the cost of inaction, which is clear and unacceptable in chronic disease, which are does not receive enough attention in most low and middle income countries, in which often the priorities are infectious disease. Well, I bring some topics of a publication that we have done in the Lancet last year called Improving Lung Health in Low and Middle Income Countries from Challenge to Solution. Well, for asthma, it's estimated that 96% of deaths in the world are in low and middle income countries. There is underdiagnosis, limited access to specialists, inadequate control, overuse of SABA and oral corticosteroids, limited access to inhaled corticosteroids, limited capacity of primary health care, and limited access to spirometry. For COPD, it's estimated that 84% of the deaths occur in low and middle income countries. There is also underdiagnosis, limited access to specialists, inadequate control, limited access to treatment, limited capacity of primary health care, and limited access to spirometry. Most of the audience certainly know well what we are talking about, and this is the reason you are here to discuss. The key message I bring to you on this matter to improve outcomes for people with asthma and COPD in low and middle income countries are four. Improve recognition to raise priority. There is a lot of neglect. Build capacity of primary health care for diagnosis and management. Increase access to spirometry and proper treatment. And finally, fight for clean air. These are my conflict of interest, potential conflict of interest. I need to disclose. Especially, I need to tell you that I'm a member of the board of director of Regina, and I'm a member of the planning committee of GARD, the Global Alliance Against Chronic Respiratory Disease. But I'm not here speaking on behalf of these organizations. I'm here providing my own opinion in these relevant matters. Well, let's begin with improving recognition to raise priority. Well, first of all, I need to congratulate Inter-Asthma for a remarkable activity globally in bringing distinguished speakers to talk about very relevant topics like the one I'm bringing today. This is a great service. We need to disseminate good quality information to get to where we want. Well, this is a publication by a group of members of GINA Science Committee on asthma management in low and middle income countries, case for change. And what you see here is the number of deaths in the vertical axis and the years, the time in the horizontal axis. And you have 4 different curves. One for the high income countries, which is the violet here down, the lower curve, and it shows a decline. Then we see in red the curve for the upper middle income countries, which is declining. There is a trend for decline. Then you see the blue line, which is the low income countries. It seems to be stable, or there is a slight trend for increase. But what really surprises us is the curve for the lower middle income countries, which is the green here on the top, which is very high and increasing. Because here, the low middle income countries, the lower middle income countries, it combines the issues of urbanization, air pollution, and the poor access to good health care. Sometimes in the very low income countries, there is less urbanization, which is a factor that is important for asthma, as you all know. Well, what do we have to do to improve this situation? There is a very nice publication from September this year by the Economist group, which you know certainly. It's called Every Breath You Take, taking the patient's voice further in their asthma journey. One thing that certainly we need to do is to involve more patients in this fight that it belongs to all of us. And I was asked to make some comments in this topic, and I stated there is a culture of neglect about asthma, and it is related to the misperception that asthma is a mild disease, a disease that affects children and goes away, which is completely wrong. Asthma may be very severe and may kill someone in an attack, even when it doesn't seem to be severe. Because of this misperception, often people do not adhere to their prescribed medication or don't have regular follow-ups. This cultural neglect affects everyone, the patient, their family, health professionals, and policymakers. We have to change the culture about asthma if we want to win the battle. And there is a lot of organization, there are a lot of people doing this, fighting for increasing the recognition, raising awareness about asthma. For instance, the Forum of International Respiratory Societies has made this campaign of the World Lung Day. It's time to act on global inequity in respiratory health, which is completely justified by what I've just shown you. Well, this organization that combines a lot of respiratory societies globally, and also GINA and GOLD, has made some publications. This one is from last year, calling attention that 200 million people have COPD, 3.2 million die each year, making it the third leading cause of death worldwide. Asthma afflicts more than 350 million people worldwide, and it's the most common chronic disease of childhood. So it deserves attention, cannot be neglected. Well, let me tell you a little bit of the work of Gina and Gold, which I think are remarkable in their contribution to disseminate information on best practice that can be adapted in each region, each country. Gina and Gold were founded by the World Health Organization and the National Institute of Health of the United States, but then became independent organizations. Professor Louis Philippe, which is the former chair of Interasthma, is the chair of GINA as well. GINA will complete 30 years next year. Well, the campaign of the World Asthma Day this year, which is an example of advocacy for increased recognition and awareness and priority for asthma, closing gaps in asthma care. And I can tell you that there is a major unacceptable gap in asthma care, which is called the know-do gap between what is known, what is possible, and what is done effectively. We all know that so many people with asthma are not well controlled, despite of the existence and even having access to proper medication. Well, the same applies for COPD, and we are around the World COPD Day, which was November 16th, and there is a new report of Gold available already. So your lungs for life. We need to take the advantage of the increased awareness about respiratory disease that COVID has spread throughout the world to get better attention to the chronic respiratory disease as well, especially because the chronic respiratory disease and the acute respiratory disease are combined. They don't exist isolated. They are often combined, and that's when things are more difficult, when we combine the chronic disease with an acute infection. Well, another good example of advocacy is the Union Against Tuberculosis and Lung Disease. It has its journal, which is International Journal of Tuberculosis and Lung Disease, and this is the report of 2022, which was just published. They state there boldly that 1 in 10 children have asthma symptoms globally, have inadequately controlled symptoms, and many have no access to essential asthma medicines. I mean, essential medicines of WHO, which everyone in the world should have access. Well, we all understand that for working in low and middle income countries, it's very important to have WHO on board because they influence very much the policies in these countries. And in 2006, it was launched the Global Alliance Against Chronic Respiratory Disease, combining multiple organizations interested in this field, like GINA, GOLD, ERS, ATS, allergy societies. Interasthma was there. And this was one meeting, the third general meeting in Istanbul. It's with a strong participation of leaders. You can see here Professor Bousquet, you can see here Professor Bateman, and we thought this would be the solution to this problem of neglect, but unfortunately, there is still low priority for chronic respiratory disease within WHO, and this alliance really didn't grow as much as we thought. A novel initiative is the International Respiratory Coalition, which has been embraced by ERS recently and has the support of many other organizations. I hope this will be strong enough to affect, to interfere, to influence positively countries. Well, let's move now to other topics besides advocacy. So build capacity of primary health care for diagnosis and management. This is the diagram of GINA, you all know well. And it has two tracks. Let's focus on the preferred track, which is defined by the type of reliever used. In this case, as needed low dose ICS, inhaled corticosteroids, and formoterol. And in the steps 1 and 2, which is the same, the first option is as needed low dose ICS formoterol. Then step 3, low dose maintenance ICS formoterol. Step 4, medium dose maintenance ICS formoterol. Then step 5, the patient needs to be referred. There is a must for phenotypic assessment, and options must be considered, like adding LAMA, adding immunobiologicals, and high dose ICS formoterol. But in this sort of situations, very, very important that the patient is evaluated by a very experienced professional, and especially if possible in a multi-speciality or multidisciplinary center that has experience with severe asthma. It's not always possible, but even in low and middle income countries, there may be some centers that do this, and they provide support to other professionals far away. Well, there is this alternative that is often important in a country that has no access to ICS formoterol, here shown in the step 1 of the alternative track, which is take ICS whenever a SABA is taken. As you know, this alternative track is characterized by the choice of as needed short-acting beta-2 agonists as the reliever. And so for the step 1, then one must combine the ICS whenever a SABA is taken. I think it's very important that we communicate well when we are dealing with building capacity of primary health care, and the diagram of GINA may not be that easy. It's a little bit complex. And I have developed this sort of image to try to make the primary healthcare professionals, not only the physicians, but the nurses as well, and other professions, and the patients, to understand that if they don't have the best option that is proposed in the preferred track of GINA, they may use this combination, which is it's available for free in Brazil for everyone in the public health system. I hope it's also available in some other low and middle income countries. I know it's not that easy in most low income countries. Well, another thing is to try to make things more simple to build capacity of primary care. If things are very complex, it's not that easy. And as you know, primary health care in a middle income country or low income countries is completely different from a primary care in a high income country. I have made this graph inspired by some Canadian previous examples. This is the severity and risk. This is the complexity of treatment. And to try to make it more simple, I think here in the mild cases, you have the option I have already presented to you before. Then we have something that encompasses steps 3 and 4, which is moderate, and then the red for the severe asthma. This is a way that may be a little more easier for someone than the GINA diagram, especially for a primary care physician. Another thing that we've been working on in building capacity of primary health care, which is something that we devote a lot of effort to recently, is an asthma attack plan, very graphically oriented, color-coded numbers, so telling people how to use the combined salbutamol and beclomethasone when they need, and what they do in case they don't improve the symptoms, and then the 3 a little worse, and finally go to the emergency room after taking prednisolone. So it's important that all the healthcare professionals, not only the physicians and the patients, learn how to deal with this action plan, which has been demonstrated in several studies to prevent unfavorable outcomes. This is another thing that we have worked on, which is how to deal with dyspnea in patients which are suspect of having asthma in the emergency care. And in one page, we made all the recommendations for how to deal with these patients with mild exacerbation, with severe exacerbations, and with the risk of death. So this is something that has been distributed to the emergency, all the emergency care units in my city of Salvador, Brazil, and was followed by a training and also by a follow-up. We continue to interact with these people, and most of them have adopted our suggestions on how to deal with this with a standardized treatment, especially avoiding nebulization, stimulating the patients to be treated with an inhaled medication with no need for nebulization because of all the complexity and the risks. Well, let's switch gears now for COPD. This is already the 2023 teaching slide set of Gold, which was released a few days ago, and has some changes. I think it's important to highlight the changes they propose. So this is the Gold ABE assessment tool. Now the categories are only 3, E, A, and B. So initially the patient has to have the diagnosis confirmed with the spirometry, then the assessment of airflow obstruction, the tradition. This is the pre-bronchodilator FEV1 over FVC less than 0.7. For the diagnosis, this is the classification of severity of airway obstruction in 4 Gold stages. But for the decision on the treatment, what is more important even is the assessment of symptoms and the risk of exacerbations, which is defined by the previous history of exacerbations, 2 or more, or 1 or more leading to hospitalizations, and here less severe, less risky, 0 or 1 moderate exacerbation not leading to hospitalizations. And here the symptoms, few symptoms or more symptoms, according to the MRC scale or the CAT scale. So the patient is classified according to the previous history of exacerbations and the presence and the intensity of the symptoms. This is what's going to define the choice of pharmacological treatment. Of course, for COPD, as for asthma, there is a lot beyond pharmacotherapy and everything related to physical activity, to healthy diet, to the environment is very important. Stopping smoking, of course, but we need to know how to choose, to personalize the choice of treatments. And this is what is presented here for this novel report of Gold for 2023. So group A, low frequency of exacerbation, no severity, and few symptoms, just a bronchodilator is enough. Group B, patients with infrequent exacerbations and high symptoms, then a LABA with a LAMA. The combination provides better results. This is very strongly evidence-based, as every recommendation of GINA is. And there's a suggestion that a single inhaler therapy may be more convenient and effective than multiple inhalers, and maybe, of course, cheaper as well. And for group E, which regardless of the intensity of the symptoms, if the patient has had 2 or more moderate exacerbations or 1 exacerbation leading to hospitalization, this is a risk factor for other exacerbations and unfavorable outcomes in general, including dying, including death. So the recommendation here is to use a combination of LABA and LAMA and consider adding an inhaled corticosteroid to this double combination if blood eosinophils are equal or greater than 300. This is a little more detail of this issue of considering initiating ICS treatment in a patient with COPD. And these are the factors that strongly favor the use. History of a hospitalization for exacerbation of COPD, 2 or more moderate exacerbation of COPD per year, blood eosinophils equal or over 300 per microliter of blood. Again, this is another point that strongly favor the use or better results of the treatment, and a history of or concomitant asthma. So in these circumstances, we must use ICS in combination with the double treatment. Some are intermediate and favors use, but not so much. 1 moderate exacerbation of COPD per year, and blood eosinophils between 100 and 300. What is against the use of inhaled corticosteroids because of its risks? And if there is no benefit, we must be careful. Repeated pneumonia events, blood eosinophils less than 100 cells, and a history of mycobacterial infection because of the risk of recurrence. So this is what guides the choice of using or not using an inhaled corticosteroid in a patient with COPD. Well, in the past, we used to think that the fate of patients with COPD was established. There was no chance of a treatment interfering with their risk of dying and even interfering with their health status in terms of quality of life, increased exercise capacity. But this is changing. This is really changing. And you see here, this is the result of the IMPACT trial. Patients with an average age of 65 years was a randomized controlled trial with over 10,000 patients with symptomatic COPD with exacerbations. And there is a comparison of triple therapy, including fluticasone furoate, meclidine, which is LAMA, and vilanterol, which is LABA, in the regular dose, compared to fluticasone furoate and vilanterol, so a corticosteroid and a LABA, and meclidine with vilanterol, the double bronchodilator, bronchodilation. So what you see here is that the group that used the double bronchodilation, the 2 bronchodilators, had a higher risk of dying for all causes than the groups that use a combination of a bronchodilator or 2 bronchodilators and a corticosteroid. So in those that have indicators of potential benefit of inhaled corticosteroids in COPD, this really may save lives. The same sort of observation was reported in another study funded by another drug company in relation to the use or not of a combination with inhaled corticosteroid. This is budesonide, glycopyrronium, and formoterol which was associated with the lower risk of dying when compared to other combinations, not including the triple therapy that combines two bronchodilators and the corticosteroid. This is a lower dose that had not so much the benefit. So 160 of budesonide twice a day. And this is 320. And this BFF, here yellow, and GFF are a combination of two bronchodilators, formoterol and glycopyrronic. So in fact, this is the combination of budesonide and formoterol here. That's provided some protection, but the protection was greater in the triple therapy. Well, let's see what we must do in order to increase access to spirometry and proper treatment. Well, there are major barriers, and this is the report of a seminar promoted by the union to discuss improving access to affordable, quality-assured inhaled medicines in low and middle-income countries. The issue of the inhaled medicine is a major point because of the concerns about the quality of the inhalers. And their conclusion is that there are opportunities to achieve improved access to affordable, quality-assured inhaled medicines in low and middle-income countries through coordinated multi-stakeholder collaborative effort that involves advocating for WHO to propose some goals, some targets that should be supported by the World Health Assembly. Well, I think it's nice to share with you that in Brazil, both for asthma and COPD, there is a very decent access to medication in public by the Ministry of Health, including biologicals for asthma, of course, some of them, not all. And also a combination of LABA and corticosteroid for patients followed up in specialized care. And there is access to inhaled corticosteroid for everyone and SABA as well for everyone. For COPD now, there is access for a combined medication with two bronchodilators, long-acting, and also one can get the free corticosteroid in pharmacies for free. I bring to you this evaluation in which the unit is each one of the 5,505 municipalities in Brazil, which were studied in two different periods, 1999 to 2001, aggregated the 3 years, and 2009 and 2011, another period of 3 years, to evaluate factors associated with a reduction in asthma mortality in Brazil. This was done by a former fellow, Dr. Ponte, who is a faculty in Jundiaí, São Paulo. So what I want to call your attention is the access to free inhaled corticosteroids, and it's associated with reduction in asthma mortality. Let's see the adjusted. Here is one age range from 5 to 24 years old. There was a double chance of reduction in mortality if there was access to inhaled corticosteroids for free in the municipality. For the age of 25 to 39 years old, the chance was triple. So the access to inhaled corticosteroid triples the chance of reduction in asthma mortality in that municipality. So it it's unacceptable that some municipalities or some locations may not still have free inhaled corticosteroids for those that need with asthma. Well, this is a publication by a group of Americans supported by NHLBI on future research direction in asthma, and I think it's very proper that we bring this discussion. So they were proposing a focus on disease-modifying asthma therapies, and I think this is extremely relevant. We need to be more ambitious in dealing with asthma everywhere, not only in high-income countries, but also in low and middle income countries, because if we raise the bar, we may get better results. And we have to aim for remission. And remission is associated with disease modification. And I think the earlier we intervene, we have greater chance of modifying the disease. Although this has been called the attention to this issue has been called recently because of the immunobiologicals, because they are so effective in some cases that we get something very close to remission that is not often seen even in milder disease. There is a very nice review on this topic recently by Professor Bussi, William Bussi, that states the following. So the title is The Holy Grail, the journey towards disease modification in asthma. And they say that novel therapies such as biologics have shown the potential to exhibit disease-modifying properties in asthma, in patients with asthma. However, it's worth noting that this has typically been observed in settings comprising small sample sizes, and biologics are only suitable for a small subset of patients. Larger studies to find disease-modifying treatments that are accessible to more patients are required. And not only the immunobiologicals have this potential. In my opinion, the better you control the asthma, the higher is the chance of getting a remission and getting a modification of the disease. So we have to aim for remission every time we see a patient with asthma. And the way to get the remission is to personalize very well the treatment in every step of asthma. Well, there is a lot done in a similar fashion for COPD, and this is a very nice publication on treatment trials in young patients with chronic obstructive pulmonary disease and pre-chronic obstructive pulmonary disease. And these authors propose that it's time to move forward in this early COPD, which starts certainly around 20 to 50 years, although the diagnosis is often made afterwards when the disease is progressive. So the time to intervene is probably much earlier than what we do now. Another very important topic which is relevant to COPD and to asthma as well is a definition of severity, definition and severity classification of exacerbations. This is the proposal for COPD. So we need to standardize the classification of the severity, and we need to try to find the etiology of each exacerbation because they differ enormously. And this is even more true in asthma. And there is the phenotype of asthma itself, and there should be the phenotype of the exacerbation because they differ. One exacerbation related to an acute respiratory infection is completely different from an exacerbation in the case of asthma related to allergen exposure. Well, to conclude, I wish to bring to you some information on breathing clean air. We have to fight for clean air. Well, this is what I call the air mud, as you see here below, which for me is the equivalent or even worse than rolling in this mud with the pigs. Usually, this is considered to be disgusting to people, and there is a lot more tolerance to this incredible hell, which is the very polluted urban centers. So I think there is a need for a culture change here as well. These are some estimates of WHO regarding household air pollution, what I call the indoor mud. 2.5 billion people cook using polluting open fires or simple stoves fueled by kerosene, biomass, and coal. Each year, 4 million people die prematurely from illness attributable to household air pollution. Household air pollution causes non-communicable disease, including stroke, ischemic heart disease, COPD, and lung cancer, and worsens asthma, as I will show you in a minute. Half of the deaths due to pneumonia among children under 5 years of age are caused by particulate matter inhaled from household air pollution. Well, this is a study that we have performed here in Bahia, Brazil, and deals with the dual exposure to smoking and household air pollution, which are associated with an increased risk of severe asthma in adults in Brazil. This was a case control study that we have planned to look at risk factors and phenotypes, biomarkers of severe asthma. And we had two comparison groups. The case group was the severe asthma group, and then we had the controls with mild asthma and the controls with no asthma. And we looked at this issue of smoking and exposure to household air pollution. Here is the summary of what we found, the main findings. Spirometric parameters of the individuals with asthma, mild to moderate and severe. So we see here those that were exposed to smoking and household air pollution had the lowest FEV1, 66% on average, even lower than the smokers here, 75, or those that had household air pollution exposure only, which was already lower than the smokers. And here is what you see with the no smokers, no exposure either to household air pollution or cigarettes. These were people with asthma, mild, moderate, or severe. So the double exposure is thermal and was associated with severe asthma. Here are my key messages to improve outcomes for people with asthma and COPD in low and middle income countries. And I should tell you that I've been engaged in this combat for so many years. Here locally in Salvador, Brazil, for some 30 years, and at the international level, interacting with WHO, with China, somewhat with Gold, Interasthma, and other organizations for some almost 20 years. So my first key message is improve recognition to raise priority and establish ambitious goals. We have succeeded here in Salvador with ProR. Build capacity of primary health care for good quality diagnosis and management. And it is possible to have spirometry in primary health care. I think the example of COVID in which PCRs were made everywhere is a demonstration that we can use technology in a simple way in primary health care where needed. Third, increase access to spirometry and proper treatment. Avoid underdiagnosis and undertreatment. This is a major problem in low and middle income countries. And finally, fight for clean air, indoors and outdoors. Don't forget the indoors, please. Well, my colleagues, my friends, this is what I wanted to share with you. And I wish to finalize with this publication of WHO called Time to Deliver, It's a report of the WHO Independent High-Level Commission on Non-Communicable Disease, of course, including COPD and asthma. It was published some 4 years ago, and it states there is no excuse for inaction as we have evidence-based solutions. And it was signed by several high-level officials, including the presidents of Finland, the president of Sri Lanka, the president of Uruguay, and some ministers of health. Thank you very much for your attention. I'll be very, very happy to discuss with you on this matter.
Thank you, Alvaro, for this very comprehensive presentation. You are the right person to speak on this matter in Brazil and to bring internationally your experience. It's very, very productive. I would like to make some comments, starting with this last slide that you presented, the cost of inaction. So we have to act, because inaction costs a lot, not only in healthcare sources, but also lives. So this is very, very important. I think this is a very good point to stress. The other thing is the critical issues on asthma. It's not only under diagnosis and under treatment, but for low-income countries is not having access to medications. And one medication you showed that changes dramatically the prognosis of asthma is that municipalities should give to patients with asthma inhaled corticosteroids. They are cheap, they are easy to use, and they must be provided to this population in order to have a good control of asthma and avoiding admissions and avoiding deaths from asthma. These, to me, are very good points that you brought up. And the other thing that is important to discuss is that GINA is updated every year and brings what we have most effectively for asthma all over the world. But one point that you brought up is maybe short-acting beta-2 agonists given with steroids would be as good as the other medications that very, very largely studied and with good evidence. So I brought only these points because your talk was, to me, important for those living in low and mid-income countries, and it brings some conflicts with what we have the most guideline, that is GINA, especially in Brazil. We are all aware of this guideline. So thank you very much for your presentation. I would like to hear your comments.
Nelson, thank you very much for your kind words. I'm especially pleased to interact with you here. You were one of my role models and still are. I think you are the most important leader in the field of allergy in Latin America. In my view, you are, and your role in interasthma is very important to all of us. I think this issue of the studies is really a problem. I say usually that being fully evidence-based is the strength of GINA, but it's also its weakness, because sometimes we are bound to the evidence, and it's difficult to propose something which is intuitive, but it's not fully based on evidence. But in the case of lack of resources in a country like ours, in many others, I think the option of using the combination in different inhalers of corticosteroid and SABA is good enough. I wouldn't lose a lot of effort in trying to change this. I think the efforts in Brazil, and I think the same elsewhere, is to build capacity of primary health care. Because what we see, Nelson, is like it was 20 years ago when I started ProR, we go to the emergencies and we see people being treated for asthma in the emergency setting. Like they go to the emergency, they receive oral corticosteroids, they receive a bronchodilator and go back home. Then they are not followed up anywhere. The primary healthcare systems say they don't know how to deal with this, and the specialized outpatient clinics are full. It takes 3-6 months for them to get a place. We don't have the specialists enough to deal with the number of people with asthma in Brazil and certainly throughout the world. So we need to build capacity of primary health care. I've discussed this several times with Tari Hartela, and I was inspired by him telling me that he did not need astrophysics to change the reality in Finland, and that he had similar problems as we have here, which is some lack of interest of many people. But he said to me that sometimes even one health professional in one health unit was enough to change the reality. Mm-hmm. That's what we are trying to do here with this training. COVID has really made it more difficult, but we are using this the new wave of virtual training capacity that we learn to reach out more people.
Great. I'm sure you are going to succeed with this new program. I'm sure of that. Alvaro, we have one question here. Now changing from asthma to COPD, what is the most effective treatment to minimize further exacerbation of COPD and improving the quality of life?
Well, if the patient has frequent exacerbation, it's very important that they receives a combination of a long-acting bronchodilator, usually LABA, but could be a LAMA as well, anti-muscarinic, or a combination of the two, which is even better, and an inhaled corticosteroid. So for a patient that has frequent exacerbations, it's important that the patient receives inhaled corticosteroids, especially if the patient has a history of asthma or something that may allergic rhinitis, or the patient has eosinophils higher than 300. In these cases, it's clear that the benefits is great. So this is the ideal situation, but of course the patient has to be protected from respiratory infections, protected from air pollution, have to do physical activity, good nutrition. So it's a combination of intervention that will provide the patient a chance to live better and live longer. I never forget a patient that I had several, I would say some decades ago. He had been suggested to go to transplant, to get a transplant because he had a severe emphysema. He was about to die. And I've been always optimistic about dealing with COPD because I always saw COPD from my bias of asthma. And I started for this patient a combination of fluticasone and salmeterol. This patient lived 6 years. If he went for the transplantation, he would survive 2 years. He lived 6 years with this combination. This is the combination that really helps. This sort of combination helps patients with COPD with exacerbation.
Good. Now we have a question from a common friend, Giovanni Viedi.
Wow.
Giovanni, he puts his question in this way. I believe that all clinicians dealing with asthma and COPD should know better the issue of air pollution and educate patients on how to protect themselves beside being clean air advocates. However, even the 2022 GINA and GO documents do not spend enough words on this issue. What do you think?
Giovanni, my good friend, you're absolutely right. As you know, Gene and Gold are very much skewed toward individual interventions for management of the disease, and they forget these environmental issues. I will take your suggestion to Gina, and I think we really need to do something. And we have some data from Salvador, I haven't published yet, which was very interesting. Salvador is in a peninsula, so it's surrounded by sea, wind, and there is not a lot of industry. So our levels of pollution are within the limits, acceptable limits by Brazilian authorities and international authorities. But I was sure that there was something that we could detect. And it took us a while, but using stations that monitor the air quality in the city, we were able to identify that some higher levels of these pollutants, although within the acceptable levels, were associated with non-atopic asthma in Salvador, non-atopic asthma and lack of control. So in atopy, we don't see the signal that clearly, but in those that are not atopic, this was a factor, a relevant factor.
Okay. Let's see if we have further questions. Well, Alvaro, I think we are arriving at the end of this webinar, and I'm sure those who attended are very pleased with your presentation and with all this information that were given in your talk. So I want to thank again Interasthma for the invitation to moderate this webinar, and I'm very glad with your presentation and seeing you in this webinar. Thank you very much, Alvaro, and thank you for those who participate.
Thank you. Great to see you.